seems so crazy that as a neurosurgeon, I can just disregard some of these other slight abnormalities, but a drop in sodium of 2 points is really going to send me over the edge. Why is that? Well, patients who have undergone brain surgery or have insults or injuries to the brain itself are very sensitive to changes in their sodium levels. The brain is in a fixed space inside the skull. It cannot expand. That will cause increased pressure on the brain tissue. Water, as we know, follows an osmotic gradient within the body. So if the sodium level in the blood drops by a couple of points, water will flow out of the vessels and into the brain tissue to try to equalize the sodium concentration across the vessels and the brain. This influx of water leads to an increase in volume inside the brain tissue. Even a 1 to 2% increase in brain volume is enough to send the ICP through the roof, which can lead to complications for the patient, such as encephalopathy or herniation. Similarly, when the sodium level drops, that can cause patients to become slightly confused, altered, or encephalopathic. That means I don't know if someone's experiencing a postoperative complication, such as a stroke or a seizure, or if it's a chemical issue due to an electrolyte imbalance in the brain. Low sodium can also lower the seizure threshold, meaning it's much more likely for a patient to experience a seizure than if they had a normal sodium level. Patients who've undergone brain surgery, had head injuries, or had ruptured aneurysms are already at increased risk for seizure compared to the normal population. So we don't need to be compounding that risk by an electrolyte imbalance. In addition, patients who've had surgery, head bleeds, trauma to the brain, these can affect the hypothalamic-pituitary axis, which is the control center for hormones in the body, specifically the way that the body concentrates urine and gets rid of free water and sodium. Patients can experience SIADH, which is syndrome of inappropriate antidiuretic hormone. This causes urine to be inappropriately concentrated, so patients retain water in the body, and that dilutes the serum sodium so that the levels drop. The other condition that can specifically affect neurosurgery patients is something called cerebral salt wasting, where the patients are losing inappropriate amounts of sodium in the urine, and this causes the sodium levels to drop. It's very important to distinguish between the two because the treatment for SIADH is fluid restriction, while the treatment for cerebral salt wasting is actually giving the patient fluids to volume resuscitate them. Treating one can actually exacerbate the other, so we need to watch the sodium levels very closely and see what the trend looks like. So these are some of the reasons I stay up at night wondering what my patient's sodium level is and why that might be the first thing I ask you on morning rounds.